Men over 55, listen closely. Right now, not in 10 years, not eventually, right now, something could be happening inside your body that has absolutely no symptoms, no pain, no warning, no sign that anything is wrong at all. And that is exactly the problem, because the number one reason men die between 5 and 6 years earlier than women is not heart disease, it is not cancer, it is not genetics. It is this: men feel fine, right up until they don't. Your arteries could be narrowing right now, and you would not feel it. Your blood pressure could be silently damaging your kidneys right now, and you would not feel it. The cellular damage that precedes the event your doctor will later call massive, it is happening right now, in men who feel completely healthy. I know, because I sit across from them every single week. There is one test, one, that catches all of it, before it becomes a funeral. Stay with me until the end, because I'm going to name that test, tell you exactly what to say to your doctor to get it, and show you what the research says happens to men who skip it versus men who don't. My name is Dr. Monty Fisher. I have spent 22 years working specifically with men over 50 on cardiovascular health and longevity medicine. And in those 22 years, I have had a conversation I never wanted to have more times than I can count. It goes like this. A man sits in my office, or more often his wife sits in my office, and she tells me he had his annual physical 3 months ago. Everything came back normal. Cholesterol, fine. Blood pressure, fine. Doctor said he was in great shape for his age. And then 2 weeks ago, he had a massive cardiac event. That conversation has happened enough times in my career that it completely changed how I practice medicine, and it is the reason I'm making this video today. Because there is a gap between what a standard annual physical catches and what is actually happening inside the male cardiovascular system after 55, and that gap is where men die. The test I'm going to show you today is not experimental, it is not new. It is published in the Journal of the American College of Cardiology, recommended by the American College of Cardiology itself, and it starts at around $100 at most imaging centers, sometimes less. Most men have never heard of it. Before I name the test, you need to understand what is actually happening inside your arteries after 55, because without this, the danger makes no sense. Think of your arteries as a garden hose. When you're young, the hose is flexible, smooth on the inside, and water flows through it easily. As you age, calcium deposits begin to build up along the interior walls of that hose, slowly, silently, year after year. The medical term is arterial calcification, and it is the single most accurate predictor of a fatal cardiac event currently available in clinical medicine. Here's what makes this dangerous. After 55, 3 things happen simultaneously in the male cardiovascular system. First, testosterone levels decline, and testosterone is not just a hormone for muscle and libido. Research published in peer-reviewed cardiovascular journals has consistently linked declining testosterone in men to increased arterial stiffness and impaired endothelial function. When testosterone drops, your arteries lose flexibility faster than they would in a younger man. Second, inflammation levels rise. Chronic low-grade inflammation, driven by cortisol, disrupted sleep, processed food, and decades of suppressed stress, begins attacking the interior lining of your arteries. This is precisely where plaque builds. Third, the standard cholesterol panel, the test your doctor almost certainly ran at your last physical, does not catch any of this. A standard lipid panel tells you how much cholesterol is circulating in your blood. It tells you nothing about how much calcium has already hardened inside your arterial walls. This is the critical distinction. You can have a perfect cholesterol number and a coronary artery calcium score that places you in the highest cardiac risk category of any man your age, and your doctor will have told you that you are fine. Let me tell you about a patient I'll call David. David was 61 years old, retired electrician, walked 4 miles every morning without fail, never smoked, took his blood pressure medication consistently. His wife told me he was the healthiest person she knew.
He came to me not because anything was wrong, but because his company offered a free executive health screening and his wife insisted he take it. He told me in our first meeting that he was only there to make her happy. He felt completely fine. His standard blood work was, in his words, boring. Total cholesterol of 190, blood pressure well controlled, fasting glucose normal. His GP had told him at his last physical that he had the numbers of a 50-year-old. I ordered one additional test. His score came back at 412. I'll explain exactly what that number means in a moment. We'll come back to David. The test is called the coronary artery calcium scan, a CAC scan. It's a low-radiation CT scan of your chest that takes as little as 15 minutes in total room time, requires no needles, no contrast dye, and no fasting. All of the preparation is to avoid caffeine and tobacco for 4 hours before your appointment. That's it. It measures the amount of calcified plaque that has already built up inside your coronary arteries, and according to research published in the Journal of the American College of Cardiology, it is the single most powerful predictor of cardiac events in patients over 55 that currently exists in clinical medicine. Here's how the score works. A score of 0 means no detectable calcification. Your cardiac risk is very low. Data from the multi-ethnic study of atherosclerosis, one of the largest cardiovascular studies ever conducted, found patients with a 0 score carry as low as a 1 to 2% chance of a major cardiac event over the following decade. That's a profoundly reassuring number. And for patients in that range who are currently on statins, data published in the Journal of the American College of Cardiology supports a physician-guided conversation about whether statin therapy is actually necessary at all, because the risk profile may not justify it. A score of 1 to 99 means mild calcification is present and atherosclerosis has already begun. Your risk is elevated above baseline. This is the range where lifestyle intervention, targeted dietary changes, structured exercise, sleep optimization, and specific supplementation produces its greatest measurable impact on slowing progression. This is the window. This is where catching it early changes everything. A score of 100 to 300 means moderate to significant calcification. At this level, your cardiologist needs to be involved in active management. Medication decisions, stress testing, and a structured cardiovascular protocol become non-negotiable. Patients in this range who are unaware of their score are statistically among the most vulnerable in cardiology because they feel well enough to do nothing while the damage continues accumulating. A score above 400, like David's, places you in the highest cardiac risk category. The multi-ethnic study of atherosclerosis found that patients with scores above 400 had a 5-year cardiac event rate of approximately 12.5%, compared to just over 1% for patients with a 0 score over the same period. That's more than 11 times the risk in people who, by every other standard clinical measure, appeared completely healthy. Here's why this test is not on your standard annual physical. It's not because it's unproven. The evidence base goes back 30 years and is published in the most respected cardiology journals in the world. It's because the 15-minute appointment your GP operates within is not structured to order it. Your primary care doctor is working from a protocol designed around population averages. The CAC scan requires a specific, individual clinical decision. Without a physician who thinks to order it, you will never know your score. That's the gap. And that gap is contributing directly to why men die between 5 and 6 years before women. If you've made it this far, you're clearly invested. You want to know what comes next. But most men watch this content and scroll away without subscribing, and then miss every conversation that follows. If this video means something to you, if the idea that a single test could be the difference between catching this and not catching it means something to you, tap subscribe. It takes 1 second. If not, you will likely forget this channel exists and miss information that could matter more than you realize. I promised I would come back to David. His CAC score of 412 told us that significant calcification had already built up inside his coronary arteries, despite perfect cholesterol numbers, controlled blood pressure, and a daily walking habit that any doctor would call exemplary. On paper, David was fine. The scan told a completely different story. We immediately began a targeted cardiovascular protocol, specific dietary changes designed to arrest further calcification, a structured exercise adjustment because the type of steady-state walking David was doing, while beneficial for general health, was not producing the cardiac adaptation his arterial system needed at this stage. Targeted supplementation informed by his inflammatory markers, and a direct conversation with his cardiologist about medication options he had never been offered before, because on paper he had never needed them. 8 months later, David came back for a follow-up. His inflammatory markers had dropped by 43%. His arterial stiffness measurements had improved measurably, and his cardiologist, reviewing the progression data, told him that the intervention had almost certainly prevented a cardiac event within the next 2 to 3 years. David looked at me at the end of that appointment and said
something I have thought about many times since. He said, "Nobody told me to ask for this test. I had a physical every single year for 15 years. Nobody ever mentioned it." That is the gap. The test exists. The research is published in some of the most respected cardiology journals in the world, but the appointment is not structured to deliver it. That is what this channel is for. Let me bring this all together. 1. The standard annual physical does not measure coronary artery calcium. It measures cholesterol in your blood, not plaque in your arterial walls. These are not the same thing, and one does not predict the other. 2. The coronary artery calcium scan is a 15-minute low-radiation CT scan that starts at around $100 at most imaging centers. It requires no needles, no contrast dye, and no fasting. Most insurance plans, including Medicare, do not routinely cover it, but health savings accounts and flexible spending accounts do, which means you can often pay for it with pre-tax dollars. 3. Patients with scores above 400 carry more than 11 times the 5-year cardiac event rate of patients with a 0 score. And the majority of those high-score patients feel completely fine in the months before their event. 4. The intervention window that matters most is a score between 1 and 99. Catching calcification at this stage, before it crosses the critical threshold, is where lifestyle and medical intervention produces its greatest measurable impact. 5. To get this test, you do not wait for your doctor to offer it. You walk into your next appointment and you say these exact words: "I would like to discuss ordering a coronary artery calcium scan." That one sentence will change what happens in that appointment. Start there. One test, one conversation. That is all this takes. Which part of this surprised you most? Tell me in the comments right now. I read every one. And if you have a father, a husband, a brother, or a friend over 55 who has never heard of this test, share this video with them today. You may not know yet how much that share will matter, but one day you will. Everything shared in this video is general educational information based on published research in cardiovascular medicine. It is not a substitute for personal medical advice. The CAC scan is not appropriate for everyone. It is generally recommended for adults between 40 and 75 who are at intermediate risk for coronary artery disease and do not already have a confirmed diagnosis. If you are currently managing heart disease, high blood pressure, diabetes, or any other cardiovascular condition, please speak with your physician before making any changes to your care. This information is a starting point for that conversation, not a replacement for it.